Добре. Наш слідуючий спікер – то є АГАТА СЕБАСТЬЯн, і в нас з університету Вроцлав. Чи ми маємо доктора СЕБАСТЬЯн на Zoom?
Запис, так? На запис? А тут підкреслено у нас АГАТА СЕБАСТЬЯн. Є запис у вас? Ну, перший автор так, але виступає АГАТА СЕБАСТьян. Є запис? А вони зараз у залі? Наживо? А, ну запускайтесь. З цього почнемо.
Ladies and gentlemen, my name is Agata Sebastian, and I would like to thank you for inviting us to give lecture about the patient with myositis and anti-MDR5 antibiotics. One of the co-authors of this lecture is my Ukrainian colleague Natalia, which will later continue the second part about this topic. And now, we would like to present a case of 27-year-old woman, previously disease-free, with no significant medical history in the past. In October 2022, she developed symmetrical swelling of the small joints of her hands with morning stiffness, typical of inflammatory diseases. In England, she was consulted by rheumatologist, and rheumatoid arthritis was diagnosed in January 2023. Sulfasalazine was used in the treatment as first-line treatment. However, after 1 day of use, diarrhea, vomiting, and low-grade fever appeared. For this reason, sulfasalazine was discontinued, and the patient was hospitalized and underwent a series of laboratory and imaging tests. Laboratory tests showed high values of inflammatory parameters, ESR, CRP, positive fecal calprotectin, and anemia of chronic diseases. Creatine kinase values were normal. A number of bacterial viral infections were ruled out, and in serological tests, the presence of anti-MDR5 antibodies and low titers of antinuclear matrix protein 2 and RO52 antibodies were observed. Full body CT showed no abnormalities, but in MRI of the muscles was described extensive, patchy, and heterogeneous myositis. The therapy included in this moment methotrexate at a dose of 50 milligrams once a week and prednisone at a dose of 20 milligrams per day, achieving clinical improvement. Unfortunately, 2 months later, the patient had a not dangerous car accident. During this incident, she suffered an injury to her index finger. A non-healing ulcer was created. Then she developed severe headaches, weakness, severe fatigue, and weight loss due to lack of appetite. These symptoms rapidly worsened and more finger ulcers appeared. Additionally, there was rhinophenomen in this moment, fever, severe hair loss, bleeding from the nasal mucosa, not severe bleeding from the genital tract, swelling and pain in the knee joints, making it difficult to get up, and mouth ulcers were present. Additionally, on admission to my clinic, there was noticeable irritability and a tendency to aggressive behavior, as well as tachycardia. In July, we admitted the patient to our department. The patient denied symptoms of stenocardia and shortness of breath. Taking into account the entire medical history and laboratory test, we suspected myositis with anti-MDR5 antibiotics and NXP2 antibiotics. During admission, we noted significant anemia, lymphopenia, high LDG and ferritin levels, significantly elevated ESR, and elevated CRP. Rheumatoid factor was negative. However, we found positive antinuclear antibodies at a titer of 1 to 320. The infection panel performed was negative. Only Staphylococcus aureus was cultured from the ulcer. The therapy included intravenous methylprednisolone at a dose of 500 milligrams daily. The patient weight was in this moment 45 kilograms. We did the methylprednisolone for 3 days. We added antithrombotic prophylaxis and antibiotics therapy, modified depending on the obtained antibiograms. Topical preparation and fluconazole have been used to treat fungal complications such as in oral localization. Cardiac ultrasound examination excluded idiopathic endocarditis. However, a very low ejection fraction of 27% and generalized myocardial hypokinesis were observed. Laboratory tests confirmed heart cell damage. In the treatment, intravenous immunoglobulins were immediately administered at a dose of 2 grams per kilogram of body weight, resulting in clinical improvement with normalization of body temperature and stabilization of digital ulcers for the next 2 weeks. The consulting cardiologist recommended performing angiography of the coronary arteries, so an attempt was made to normalize the tachycardia pharmacologically, which ultimately failed. In parallel, pharmacological therapy for heart failure was initiated. In the following days, multiple imaging tests were performed. The abnormalities included interstitial changes in the lungs, up to 25% of the lung parenchyma, and fatty liver disease. Acute myocardial was confirmed in cardiac MRI. This test was performed 4 days after the administration of immunoglobulins, and an improvement in the left ventricular ejection fraction of up to 40% was already visible. The treatment additionally included mycophenolate mofetil, which resulted in the appearance of a small papular rash located all over the body. An MRI of the brain was performed, which described bilateral hyperintensive lesions indicating vasculitis. In the following days, the patient began to report severe myoclonus when failing asleep and wake up screaming at night. So electroneurography was done, which revealed seizure lesions, and levetiracetam was included in the treatment. Cyclosporin was used in the treatment of the underlying disease, intravenous glucocorticosteroids, and immunoglobulin were continued, but the full remission wasn't achieved. Laboratory tests showed increased drug-induced liver damage. So, cyclosporin and potentially hypotoxic drugs were discontinued. Rituximab, and we administered rituximab at a dose of half a gram every 14 days, resulting in significant clinical and laboratory improvement and slow healing of the ulcers. In conclusion, central nervous system involvement in dermatomyositis is seldom observed. There are rare cases reported of CNS involvement in juvenile dermatomyositis. Regan and his group described the first case of CNS vasculitis with refractory dermatomyositis in adults. And Dalman et al. Reported a case of dermatomyositis with positive anti-MDR5 antibodies associated with neuromyelitis optica spectrum disorder, probably due to the fact that the two diseases are both B-cell mediated autoimmune diseases. Our case is the first case with CNS involvement and anti-MDR5 antibodies in adult person. Other more common organ changes in the course of dermatomyositis with anti-MDR5 antibodies include myocardial involvement, progressive ulcers, and rapidly progressive lung lesions. The treatment strategies for dermatomyositis with anti-MDR5 antibodies require aggressive immunosuppressive treatment due to the progressively aggressive nature of the disease. Thank you for your attention, and now I would like ask Natalia to continue the lecture. Thank you.